The College of Medicine at the University of Saskatchewan is officially under new management. We have a new dean, a pediatrician, one who's passionate about making lessons at med school stick.
I got a fever, I can't relax, can't sleep, my throat's on fire. Don't touch me, I'm a real big crier. Strep pharyngitis, qu'est-ce que c'est? Swab, 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 swab. I want my penicillin right away. And my doctor said no. So I said, oh, 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 and I hurt my throat.
That is Dr. Sarah Forgie playing, and that's the kind of teaching strategy that led to a 3M Teaching Award for her. It propelled her into university leadership. This summer, she became the Dean of Medicine at the University of Saskatchewan, and Dr. Sarah Forgie's our guest today on Researchers Under the Scope. Hi, I'm your host, Jen Cannell, and we sat down to record this on the 4th floor of the Health Sciences building just a little bit earlier in this month. It's October of 2024. I sat down in Dr. Sarah Forgie's office. She's a pediatrician. She's an infectious disease specialist. She's a university leader whose research has taken her in multiple different directions. As of July 1st, she took the wheel at the College of Medicine. And here's what happened when we sat down together. Hello there, Dr. Forgie.
Hi, Jen. I'm really excited to be speaking with you today and telling you a little bit about my journey to get here.
Can I just ask about the Talking Heads clip?
Rheumatic fever, arthritis, pharyngitis, rashes, cornea. Post-strep sequelae would really suck. So I don't think you should press your luck.
Where did that come from?
Oh, that is an excellent question and embarrassing. Thank you for revealing that, because I usually only do that in front of the medical students. But
I'm here for you.
I think this started back when I was a medical student. We had 8-hour days where we were in the classroom pretty much all the time for the first 2 years. So in the classroom or in the anatomy lab, a little bit of clinical exposure. And what I began to realize were there were certain professors who would teach things and it stuck in my brain, and others not so much. So it required a lot of revising, learning, relearning. And so when I moved to the University of Alberta in 2003, not really knowing that there weren't rules, I just started doing things. And so for every session that I taught, and this was usually related to bacteria because I love bacteria, I would try and have a memory hanger. So whether that was a visual or a song or a story or something else, then I would challenge the medical students and the dental students that I taught to do the same thing. So with every session, I would do something, they would do something, and it just made it a really fun environment.
Well, it wasn't just the Talking Heads, was it?
It was not just the Talking Heads. And I only know one song on the ukulele because I actually play the piano, but I could not figure out how to get a piano into our lecture theater, and a ukulele is small and transportable. So I learned that one song, and that was about strep throat. And the key messages around strep throat were a lot of times people have a sore throat, think it's strep, come into their physician wanting antimicrobials.
Give me all my penicillin.
Exactly. I want my penicillin right away is what the patient is asking for. The message I wanted to get across was, use antimicrobials wisely, do a swab, confirm the diagnosis, and if it's positive, treat. And there's no urgency to treat. So it will reduce the symptoms by about a day, might reduce how transmissible you are, but really it's symptomatic care. And then if it's positive, to treat to prevent rheumatic fever. So that was the message in the song, sung very horribly, but it did get laughs and it stuck.
And everybody who's been through that class now remembers swab, 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 swab. They do.
It is true. That is true. And my youngest child, who is now 17, when he was about 3, would run around the house singing the song too. So it was actually quite fun.
Memory hangers for everyone.
Exactly. He knows how to treat strep throat.
You did like Lord Royals,
Yep.
the Dave Brubeck
Yep.
Take 5.
Yep.
Okay, what happened with the Take 5 one? What was that about?
Okay, the Take 5 one was actually an idea I got from my children's piano lessons. And I was watching her tell a story about a polar bear set to an orchestral piece, and you could see the children's faces, like something scary was happening. They could tell from the music, and I thought, can I do that in my bacteriology class? So I told a story set to the Dave Brubeck Quartet, where each of the instruments was a bacteria or a bacterial group in a human's abdomen.
Do you remember what you chose? Like which instruments you chose?
Well, it was my favorite one was Bacteroides fragilis, which is an anaerobic bacteria in all of our guts, which was on the saxophone. So what I did was it took me a long time, but I created a story. I dressed up as a beatnik poet, and I told this story like in a jazzy way about how Harry Houdini died from an abdominal abscess. So it's kind of this interplay between here's all of the organisms in your gut, and here's how they're playing the instruments, and here's what's happening. Oh, let me tell you about Harry Houdini. And there's a big interlude in the Take 5 Quartet where there's no saxophone playing. And that's exactly what happens in your gut when an abdominal abscess is forming, because there's a rupture or a reason for the bacteria to get out of where they're supposed to be. And it's aerobic. And so as the tissue becomes devitalized, as the bacteria start using up the oxygen, Bacteroides fragilis is an anaerobic bacteria that can actually survive the exposure to the oxygen because it's got certain factors like superoxide dismutase and things that will help break down the oxygen-free radicals. So it's waiting for its time to shine. And so I'm telling this story about Harry Houdini, and I'm like, wait, here's the saxophone. Because now Bacteroides fragilis can come in, start multiplying, and stimulate the abscess formation. And so, like, the students are like, "What?" But it is a little bit tricky. I'd always have to have my stopwatch like ready to go, and I had it all blocked out. So every year I would tell that story, and I actually studied it. So what I found was 98% of the students remembered immediately after, and 6 weeks later, the story about the abscess formation and why Bacteroides fragilis was important, why it survived the exposure to oxygen. But then I also had an accompanying lecture, so I asked questions based on that. That was about 50 to 60% recall rate. So it worked.
It really worked. See, test the theory.
Yep, totally. And I had a really nice publication with it, and actually the editor of the medical education journal reached out to me. He worked in England. We still communicate today because he was an educator. He continues to be a really amazing educator and scholar there. And so we swapped ideas about, how did you teach this and what did you do around that? And so it was an amazing connection for me.
Well, looking back at it, even when you decided to go to med school, did you know from the time you were a really little kid, oh, this is definitely what I'm going to do?
I did. I did briefly think about vet school because I do love animals and treating animals. But I think medicine was always something I wanted to do, and for many different reasons. Like I do love the idea of helping people and helping make their lives better. But what I also loved was how many opportunities there were in medicine. So I've headed on the clinical path, love the work that I do in pediatric infectious diseases. I continue to do that.
Even here in Saskatoon.
Even here in Saskatoon. In a couple of weeks, I'll be on clinical service. And so very excited about that. And then the teaching, but also the leadership. And I think what is so cool about medicine is you can morph what you do over time. There are so many opportunities and so many ways to make things better, whether it's at a population level around influencing policy, or it's at a one-on-one level interacting with a patient, a parent, or a learner. So it's cool. I think it's very cool, and I'm very lucky.
So who were the influences that made that happen?
Yeah, that's a great question. The biggest influence would be my mom and dad. My mom is, she's an amazing lady. So she grew up in South India. And when she was 16, what happens in India is you finish school, and then you have the option of doing a few more years of whatever, and then going to university, or you can take different paths. So what her family said to her, my grandfather owned a typing school in Mangalore. He said, you're going to go to typing school, and then you'll likely get married and stay at home with your children. And my mom said, there's nothing wrong with that choice, but it's not the choice for me. And she said, I want to go to medical school. So they asked her if she would stay in Mangalore to do 2 years of science, and so she did. And her younger sister, so my mom's name is Mithra, her younger sister Sumati, what they decided was my mom, Mithra, and Sumati would go to Delhi, and Sumati would do her 2 years of science while my mom started medical school. So they both went to medical school in New Delhi at an all-women's medical school, which still is there today, Lady Harding.
Wow.
And it's such an amazing story. And so I think about her basically turning around and bringing along other women in the family.
Yeah. And also to have your sister there with you. I could see sometimes you might bicker, but that's an incredible support when you're so far from home.
Yep. And they lived with my uncle, my great uncle Gopi, an amazing man. And then my mom said, I want to do further training. She thought about becoming a surgeon, moved to England, and that's where she met my father. And so, long story short, as an interracial marriage, things were not favorable in the UK.
This would be like the 60s, 70s?
60s, yeah. Ooh. So they moved to Canada. And so they both went the family practice route, and we lived in northern Manitoba.
Wow.
Yeah. How did we get to northern Manitoba? My dad had job offers in Hamilton, Ontario, Dauphin, Manitoba, which is just north of Winnipeg, and Lynn Lake, Manitoba. And he had no idea, looked at the map, and thought Lynn Lake looked like the Lake District in the UK, and he picked Lynn Lake. So that's how we wound up in Lynn Lake.
And how far was it from Winnipeg if you wanted to drive?
That is a good question. I don't even know how long it would take to drive there.
It was more of a fly-in?
It's definitely a fly-in. I mean, you could drive it at certain times of the year. When I did my pediatrics residency in Winnipeg, we all had to go to Thompson, and that was about a 7 to 8 hour drive. And this was further north. So it's north of the 56th parallel.
Oh, so you are very good at short bursts of daylight in the winter.
Oh, absolutely. I remember being little, and it was like daylight forever. And so my parents were like, "Go to bed." And yes, and we were like, "But it's still daytime," and it was midnight. But
Because when she got to Canada, she was still a physician here, and your dad was also.
So my dad was a physician. He was able to practice here because he had trained in England. But she wasn't. So she had to do her family practice exam. So I remember driving in a Jeep from Lynn Lake to Calgary so my mom could do her family practice exams. And then she was able to practice. And when I got older, we all moved to Winnipeg. And she did what she called like a young woman practice. So she loved seeing young women, especially as they went through their, she would do all the deliveries and then she would see the kids. And my dad did mostly geriatrics, so mostly elderly people. So they had a nice split in their practice where he was seeing the older people and she was seeing the younger people, and they really loved it.
Oh, that is cool.
Yep.
And in terms of you, I know you mentioned that you had looked at veterinary medicine.
Yeah, just briefly.
Humans were more fun.
Humans were more fun, yeah.
And why pediatrics?
Oh, well, that was not on my radar. So I like to tell medical students this story because my plan was, I did my undergrad degree in microbiology and immunology. I adored immunology, and I thought, okay, I can do that in clinical practice. I don't think I'll like pediatrics. So I even set up, because we were able to choose what our rotations would look like in third and fourth year, I set everything up so I would be internal medicine. So doing adult medicine, adult surgery, obstetrics. I did all of the things, and I did pediatrics near the end. And it was like a revelation to me. When I got there, I thought, I had no idea I would love this so much. It's like internal medicine. Apologies to my adult colleagues, but what I thought was it's like internal medicine, but fun. And I just had a blast doing it. And the people that I worked with were so amazing, like caring for the children, caring for the families, thinking about prevention in the community, the anticipatory guidance as kids go through, when are they wearing the helmets? What about the car seats? Things like that. So I just loved it. So it drew me in, and was still thinking about the immunology path, but really got more drawn towards infectious diseases, and had some amazing mentors in that realm, and haven't looked back.
And that brings us to present day, teaching and how people need those little memory hangers. And the master's that you did in education, this is all about cultivating better clinical reasoning for these med students. Where did that start to occur to you as, no, I really need to look into this?
Yeah, that is a great question. I think I wasn't that metacognitive when I was a medical student. I did think about, why did this stick and why did that not? But I think as I started teaching more, I had so many medical students, I would talk to them in the course that I taught was right at the beginning of first year. And I used to joke that these are basically people who so desperately want to be doing clinical reasoning and how do I get to the point where I can diagnose X, Y, or Z? And I would say to them, you're not ready yet. It's a combination of learning and time and experience. And so then I started thinking, is there a way to do that faster?
Can we accelerate this?
Exactly, because, it does cost a lot to educate these medical students and it takes a lot of time. And that was my master's thesis, was interviewing colleagues about that exact question. Like, how do you take the pieces that you're learning over time and start to put them together so then you can actually start to go through pieces more quickly? So I'll walk into a room now. Let's say I'll see a child who comes in with a certain constellation of symptoms, and I'll start thinking, I know that's pneumonia. Is that bacterial pneumonia? Is it viral pneumonia? I'll start running through the symptoms, and then what do I think is the most likely pathogen? How am I going to treat this? And so I'll move through that. But when you're a medical student and you're just starting out, you're like,
here's this constellation of symptoms.
Yeah, they're coughing. And so how do you get to that point where you can, they call it encapsulating knowledge, where you start encapsulating it, moving through faster. And we know that with learners that are a little bit further along, so let's say a resident at a resident level, so they finish medical school, they can get to the same answer as a more seasoned clinician. It just takes them longer. So it's just, so those were the pieces that I really started to think about. And one of my favorite questions that I asked in my thesis was, where are those moments where a medical student's telling you a story and suddenly you realize they are not on the right path? And what does that feel like? And I remember colleagues telling me it felt like a visceral reaction, like there's like a clang that happens where you're like, nope, this is not pneumonia. This is something totally different. And so because that was the other piece, like how do you pull students off the path, because there's all these biases that we have. You start heading on a path and you're like, clearly it's pneumonia. And then, a more seasoned clinician comes in and says, no.
Come back from the cliff
edge. Come
back.
Yeah. How do we get you back here? So it was not only the path of clinical reasoning, but also trying to avoid some of those offshoots that might not be the right path. So, yeah, that was a really fun experience for me, I have to say, and just trying to learn that and teach it. And so, yeah, it's been something that I talk about with students every day now when I work with them on the wards, that here's some ways I can help you accelerate this reasoning, and here's some ways that you can avoid some of those biases. And so it's been good.
Sounds like you really do like being hands-on, being on the wards now and then.
I do. I think it brings me back to the big reason that I did medicine, and that's to really help children and their parents. What I love about infectious diseases work is that in many ways I can fix things. So it's, you've got this skin infection and I know what the bacteria is and I know what antimicrobials are going to work. So let's do that and we can fix it. And how can we also do it in a way that's thoughtful, where we're not contributing on a larger level to resistance and antimicrobial resistance, and do it in a way that we prevent side effects for the child who's taking the antimicrobials. So it's all of those levels I like to think about as I'm moving through, but the biggest part is just being helpful.
Where do you sort of see the U of S right now, and where do you see us going in terms of the College of Medicine?
So I like to ask people, if I had a magic wand and I handed it to you, just with the caveat of I don't actually have a magic wand, what I would love to see in Saskatchewan is that every physician in the province approaches the work that they do with an academic lens. And by that I mean whether it's teaching and they're looking at ways to study the scholarship, or it's their clinical practice and they're looking at ways of how can I bring in some quality improvement principles and study this to make my practice even better. Or how can I connect with a basic science researcher at the university to do things even better? How can I connect with a clinical trialist at the university? So ways at the College of Medicine, I would love to see ways that we can support our colleagues all across the province to use an academic lens in their work. So that's my magic wand moment, that's what I would love to see at the end of my tenure, that everybody's using that academic lens and that they feel a connection back to the College of Medicine. And within the College of Medicine itself, I see tremendous opportunity. So there are amazing researchers here in the biomedical sciences, doing clinical trials, doing that quality improvement work, and the scholarship of teaching and learning. So there's all of these aspects, and so I would love to continue to build upon it. I've had lots of conversations with people here, with people in the government as well, they're really curious about how do we do this better? How do we actually improve the health of Saskatchewanites. I'm not sure what we're called. People of Saskatchewan. But
Saskies.
How do we,
Yeah.
Saskies, I like that. Huskies. How do we improve the health and also have learning healthcare systems? So I think there's so many opportunities, and I think it has to be multifaceted and it has to be collaborative. And so that's what I would love to see, is more collaborations, both within the College of Medicine, to our colleagues in the community, but also with the university, government, communities, more collaborations overall.
Reach outside these university walls.
Absolutely. So something I have been incredibly passionate about in my more recent leadership roles, but it's always been something I've been passionate about, is actually studying ways that we can work with First Nation, Inuit, Métis communities to better prepare our trainees to work with and in these communities. And so I have an amazing team that I've been working with and made some new amazing connections here with Janet Tatusis, who's our Vice Dean Indigenous, and the Office of Indigenous Health and Wellness. But looking at ways of how do we do that better? How can we collaborate and learn about Indigenous ways of knowing and bring in more meaningful connections with community?
Yeah, without it feeling like, oh, we're going to tell you what's good for you.
Absolutely. No, I don't want to do that. And I don't, because I don't know what those answers are. And I wouldn't want that done to me. So I am all about collaboration. My joke is, if I had a t-shirt that would define my deanship, it would say collaboration. Collaboration and connection, because that's what I love to do, connecting, whether it's with the university and historians and philosophers and engineers, or colleagues in the community, or basic medical science researchers here, or grad students, med students. I love connecting.
Well, and I think about, like, if I'm, say, a family physician and I'm reading this at my office in Estevan or in Swift Current or wherever, and I'm going, oh, collaborate, look at my things with an academic research. Okay, you're asking me to do more work. I already feel burnt out.
Yeah.
And this is a thing that we see in places like Manitoba, Saskatchewan, Alberta. When you're outside the major centers, it does feel like we're stretching our medical people so thin. And in terms of not having quite as much turnover in those smaller centers and just letting people shine where they can.
Totally.
What are the best or conversely the worst ways of doing that?
Yeah, it's a great question. And I'm super excited to say I've been to Swift Current, I've been to Estevan, I've been to Yorkton, I've been to Moosomin, I went to Larange, and I got to meet amazing people in those communities who are so excited about what they do and they want to share what they do. And they also are so kind and passionate about sharing what they do with our learners. So I think that is the connecting piece where we can actually make things even a little bit better for our colleagues in the community, not only by creating the connections and helping with things of how can the college help, through our continuous professional development programs, help you with your practice or some of the things that are worrying you. How can we connect you with our learners who they're always asking questions. I love that because it's like, because it makes you think. And they also serve as a connecting pieces back to the College of Medicine. And so looking at thoughtful ways, because that's the other piece about, I like to ask and say, what is valuable to you? How can we help? And how can we reduce some of those feelings that you're having around burnout and frustration. And so again, studying that and helping with that leads to a virtuous cycle of how do we make things better in Saskatchewan?
How long do we get to keep you for?
As long as you'll have me.
Fantastic.
And I need everybody's help because this is a massive ask. Every interview I go to, it's like, how are you solving the healthcare crisis? This is not something that we're going to do alone. We need creative ideas. And again, it has to be multifaceted. So looking at that in many different ways. So I need help.
Yeah. Barring magic wands, I think.
Barring magic
collaborating.
wands. This is true. This is true. But yeah, the collaborating and connecting.
Thank you so much, Dr. Forgie.
Thank you. This was a wonderful, wonderful talk.
Dr. Sarah Forgie is a pediatrician. As you heard, she's originally from northern Manitoba. This summer, she came to the University of Saskatchewan after she spent more than 2 decades in Edmonton at the University of Alberta. She is now the Dean of the University of Saskatchewan's College of Medicine, and that means, she oversees it all, including the latest posts and research that you can find all at medicine.usask.ca. Researchers Under the Scope is a presentation of the Office of the Vice Dean of Research here at the U of S College of Medicine. We record this podcast on Treaty 6 territory, and we pay our respects to the First Nations, the Métis ancestors of this place, and we reaffirm our relationship with one another. This is also where we have to thank you for tuning in. I'm Jen Cannell, I'm your host, and whether you're following us on Spotify, on YouTube, on Apple Podcasts, go ahead and give this show a follow, give us a review, tell a friend about it. Thank you for tuning in to Researchers Under the Scope.